Kia ora koutou and welcome to Goodfellow podcasts. I'm Dr. Helen Carr. I'm a GP. And today I'm speaking to Carla White, a Director of Health Literacy NZ, about how to navigate challenging consults when medical misinformation or distrust of science is at play. She is Ngāti Tama and Ngāti Toa Rangatira, and she has worked in health literacy for over 15 years and has developed some of the key New Zealand health literacy resources, such as Roimi Atawhai, the Ministry of Health's Guide to Developing Health Resources, and has worked alongside many different health organisations on important projects to improve access and participation in healthcare. It's no secret that trust in scientific institutions and traditional experts is decreasing. People are often turning to influencers and peer networks for their health information. And often these are people who can project authenticity, and they often provide simple and quite appealing answers when the truth might be actually a bit more complicated than that. So I'm interested to hear from both a health literacy and a communications expert on how we can respond to this at a clinician level. Thank you, Carla, for joining me today.
Thank you, Helen. It's great to have this opportunity to talk about, the changing landscape and the experiences across healthcare, but particularly in primary care. I think it's very true, this idea about misinformation being circulated and that creating distrust or uncertainty, I suppose, is how it manifests. I think too that we have to remember that our system has changed so much, our provision of services has changed so much that we want people to be engaging with all the information out there. You know, we're putting information online like never before. We're creating content, we're putting up QR codes, we're hoping that people will look for information because we're not able to provide that kind of lifelong, personal care that once we could, we don't have the time. So we've changed the landscape, we've had to, but of course that means that the ability for others to come in and influence that the information that's available and serve different purposes has really increased. So it's incredibly challenging sometimes for people to be able to discern between, what should I be reading and what's not so accurate. We've got that overall change in how we work. We want people to be involved in shared decision making, to informed consent, that we want them to become, self-managing. So we're putting a lot on people. And so the ways in which they're choosing to do that present a different kind of challenge. Yeah.
So I wanted just to start with some cases. So patient comes to you with newly diagnosed type 2 diabetes, but they're hesitant to start metformin. He's read online that it can cause liver damage and is instead taking an alternative glycobalance product. His father died shortly after he was started on a new medication for his diabetes by the GP. So all of that is at play. Talk me through how you might navigate this consultation.
There are sort of three things that I'd be thinking about there from a communication perspective. First is the importance of empathy, and both in terms of what happened for his father and the family in that situation, but also the clear uncertainty that this person is facing and the underlying worry they have about their diabetes at the same time, right? So it's sort of exploring a bit more about, I hear you're uncertain. Is it about all medicines? Is it very specific because of, what happened to your father? What's the discussion that's being had around this? So just recognise that. I think then there's a couple of things to think about. Uncertainty is a stage of change. So if we're thinking about the trans-theoretical model of change and we're thinking about stage 2, it can be about exploring pros and cons. So both the pros and cons of making a change and of not making that change, right? So everything comes with options, but sometimes we're only thinking about, say, metformin in terms of the pros and cons and not if I don't take it, what's going to happen, or if I do take an alternative, what's going to happen, So rather than suggesting that one pro is more important than another, getting some of that down and then helping people work out, so for you, which of these is most important. And then, of course, from a health literacy perspective, you've got ask, build, check, which is finding out what somebody already knows, which is partly what's happening here, because you have to establish their schema. So what do they already know about diabetes generally? What's their lived experience? So it isn't necessarily facts and the science, but what's been their experience. So part of it you have with the father, what else happened? Do other people in the family have this? What's the journey that they've been on? Just get a little bit of a frame. What other things do you know diabetes affects? You're getting their picture because you want to try and connect anything new that you're going to provide to that picture, because then they'll hold on to it. So you want to find out, for instance, if they know some of the risks associated with diabetes, because that's why you want to be talking about a medicine that brings that blood glucose down. They have to see that it's not just about HbA1c as a number, but what that represents. So your building is attaching to the bits they already know and saying, yes, that's exactly right. So this is what we're worried about with your heart, for instance. You want to reinforce that they do know stuff, they bring stuff that's important, and then work out where to attach the new information. And it also tells you sometimes where things have gone slightly off. So this happened to my dad. Diabetes is a really serious illness. Was it the medicine? Was it something else? Can we talk about that there might have been a number of things at play in terms of late stage diagnosis and treatment and things like that. So was it the medicine? Was it other things? And then you're checking what people are leaving with. So that's our ask, build, check.
Sometimes it could be tempting to just say things like the facts are that metformin doesn't cause liver harm,
Yes.
or it can in very small circumstances. Is that sort of negation of facts a useful approach, or is it too confrontational?
I think that it probably is, and that what you're just telling somebody there is you're wrong, right? And a much probably more productive relationship way of doing this would be to say, in a very, very small number of cases, over millions of cases, however you want to describe it, there might be a tiny effect on the liver compared to the benefits for your kidneys, for your heart, for whatever it is. You want to talk about kind of the scale of the risk compared to the scale of the benefit.
Yep.
The more you can help people understand where the information they have and have retained enough, they want to come and talk to you about it, where it sits in the schema, so it doesn't become this red light. It just becomes this, that's an interesting little aside, right? So it sits there still, but I've got a bigger picture now. All right, it's much easier to do that, to grow, and add and round out people's picture, than to try and tell them to get rid of something. All right, it's a bit like a plant. You graft on some new information to the bits that are healthy, and that grows a new plant, and the other stuff withers away. All right, you try to chop it off is not good. It's not going to be a great use of your time. It doesn't help the relationship either. So you're trying to build a relationship where your job here is to make sure the follower patient is really informed. That's the goal.
And I wonder whether checking how much information they actually want to know in the first place is useful. Sometimes it feels like you just start talking at someone and they just put a bit of a wall up and they're not that interested.
Yeah.
Do you have any tips on sort of the ask part of the ask, build, check? Any example questions or things that you find would be useful for figuring out what they actually want from you?
So the challenge with ask, build, check is, you can get too much. So you can, or if you ask a question that sounds more like a science test, like, what do you know about diabetes? You'll probably get, not much. Whereas if you say, tell me about your experiences with diabetes, you might get a completely different picture. People are usually happy to talk about their own experiences and engage at that level. But if you turn it into sort of a description of facts, then some people love that, some people don't. So if you can try and tie it to experience, that's usually a much more open thing. However, if the question sort of, what do you already know, is shut down, or any question you ask is shut down, what are your experiences? None, but I've read online what it's all about. I know where I'm starting. I think you have to think of that more as a stage one kind of experience where somebody is very much, I'm not ready to go to that next step. Then you can ask those fantastic questions from Dr. John McMenamin, where he talks about, do you have any concerns about your health? Do other people in the whānau have any concerns about your health? Is it okay if I share my concerns about what you're talking about, right? So it's this permission and inquiry kind of thing. And once again, that opens it up to a slightly different discussion, and people don't feel forced upon with information. If they say, no, I'm fine, then you've still created the kind of relationship where if you ever want to talk about this some more, come back. I'm happy to talk about this. It's a really important thing.
That leads on to another case where someone who is on warfarin for a mechanical heart valve, so if they stop taking it, the implications can be really serious. So I've had a patient come and say, look, I've decided after being on warfarin for 30 years or whatever, I've had enough. I've possibly read something or someone's told me something. I've stopped it and I'm starting this new extract that I've heard is just as good but safer. Ultimately, people have the right to make their own decisions, even if we disagree with them. But in this situation where the consequences are possibly really grave, are there any particular considerations we need to have to make sure that we have actually really communicated the risks adequately to them? It's not just that they
get to decide,
Yeah, get to decide.
Well, that you want it to be an informed decision. So I think similarly starting off with thank you for telling me, because it's really important. I think it's still a pros and cons discussion, but it might be about stopping warfarin, all right? And it could be about the alternative. So you want to be really clear that your concerns are about the cons of stopping. In the end, if somebody still decides to take the supplement, I think that the best outcome would be, all I want to make sure is that we're monitoring whether or not this is working. So it's about regularly testing to get the information we need to see what's, is this sufficient for you? That's all we're worried about. Is this sufficient for you? I think with the pros and cons with something like warfarin, you can both talk about the risks of not taking it. You can talk about how to manage the risks of taking it. I am not saying you have to or you must, it's the only option. We're just looking at the pros and cons, and hopefully the pros of warfarin far outweigh the cons and the pros of something else. Presenting it that way too, it very much keeps the control with the patient, which is also what you want them to feel, that I made this decision, I can make another decision here, rather than, but you want me to do something else.
So what's some language or examples of that pros and cons discussion that you'd recommend? Because I imagine it's how we say it that can be quite important.
Yeah, I think saying, look, I think what's really important here is to explore the risks and benefits of both options. So let's just make a quick list of the things that you're most concerned about with this, and that, and I can add in on some of the pros of this, and let's just do a quick brainstorm and see where we get to, because I want to make sure that you've got everything that you need to make this decision, because it's a big one. We do talk about pros and cons, risks and benefits. People like to know, or we find that when they hear informed decision making, that's what it should be. I'm not only hearing one side, that there's acknowledgement that everything comes at a cost. Look, walking comes with the risk of, a leg injury when you're over 50, explore it. Nothing is without consequence.
And what if someone is quite hesitant to explore it? If they say, no, I've done my reading, I'm not interested, I've made my decision. What then?
I think go back to that. Does anybody else have any concerns about your well-being? Is it okay if I share my concerns? I'm always here to talk about this, right? I think your earliest point about I need to just make sure that you're aware of the risks of stopping warfarin, for instance, in this case. Because you want it to be that if any of these things happen, please come straight back. We can talk about this again.
Any tips that when you're talking about risk to someone, is there data about whether people prefer it with like 1 out of 5 or percentages, or, is there any kind of way that is better to present risk than others?
It's probably the trickiest part of the communication, because to one person, 1 out of 100 sounds like low risk, and to another person, that sounds like it's going to happen to me. So there's this whole personal threshold thing. I would say whole numbers are better, so 1 out of 100 rather than 20% of people or a fifth of people or that sort of thing, so whole numbers. But whatever you do, try and use the same scale for each thing that you're comparing. So use whole numbers each time, or ratios rather than percentages or fractions. Yeah, neither of those work so well. If, however, somebody's talked to you in percentages already, like I've heard that 20% of people end up with X, then use that. Go with their language. But if you're introducing the risk sort of analysis, or then I'd go with whole numbers. A lot of times research isn't actually presented in that way, so it's quite hard to work out how to do that, but there'll be versions.
Yeah. So another case here is someone who comes to you and has done a whole lot of research about their condition, and it's not a condition you see all the time, and they just seem to sort of know. They've read all the papers about different expert opinions, and they want to come and have a chat to you as a GP, as a generalist, about their condition. Sometimes that patient sort of strikes fear in us a little bit. Could you talk us through your approach to this?
Empathise with the emotion behind that need to research or that desire to. So clearly this is something that's really important to you and you're doing a lot of work around this. Is there a particular thing that's motivating you in terms of, are you worried about a particular outcome? Are you worried about particular things, or are you just generally interested? I get somebody might have had a diagnosis, but there might be at their forefront, there might be some flashing things going, but what about this? What about this? What about this? So that can help focus the conversation a little bit. If they say, oh no, I'm just generally sort of interested, I've been thinking about, what is this going to look like long term, then talk specifically about that. Ask them, are there points that you've found out, or are there things that you found out that surprised you or concerned you? So try and get into the of it without this sort of whole general, so it's this and it's that, and maybe I did it, maybe this caused it. Not so much. You want to get to the things that are really stuck with them and why. So you could ask that sort of, what has struck you from the information, what's been really important that you found out, and go from there. And this is where the ask, build, check comes into its own. We always thought that asking to find out what people know, and by know, we should talk about knowledge isn't just facts. Knowledge is lived experience. So that's why it's really important to ask people what they've experienced, what's gone on for you. What have you experienced in this? What's happened so far? What do you worry about with this? What did you try? Why? Why? That gives you knowledge, their knowledge base. But you want to try and find that out, because otherwise you are talking at cross purposes at the build point, because either you're telling them stuff they already know, when instead you could have gone, exactly, that's fantastic that you already know this. Reinforce the good stuff. Keep doing that. If they can share with you, say exactly what, like you were saying, this is the important thing. Like you said, you've got this already, perfect. So find out what you can. If, like if somebody is saying to you, every time I eat a mussel, or actually any man in my family's ever eaten a mussel, the gout is with us by nightfall, And so for them, so one fact is I have a mussel, I get gout. The next thing they associate that with, therefore mussels cause gout. Therefore, the way to stop gout is to stop eating mussels, right? So, and that gout is a temporary condition. And so if you can find that out, you can attach to a couple of things that you said there. One is about the mussels and the uric acid and, purines and stuff. So yes, there's that there, but you also mentioned it runs in your family. So that's where you start grafting in the bit around how come your body holds on to so much uric acid in the first place. The muscles are just the trigger you can see, but actually it's the underlying thing that's happening. And so people aren't being told it's wrong. It's not that, they're being told that, so this is, my picture can shift slightly, my tree can grow in a slightly different direction, and I've still got that. I'll hold on to that. That makes complete sense to me. So if you just instead say, somebody says, oh, this is my experience of gout, and so it's caused by mussels, and you say, oh, no, it's actually probably more about your genes, and they're thinking, you have no idea about my experience of gout, but you've never had gout, what would you know, right? So same information, just delivered differently. If you can connect to their story, you have them, and they will remember it, which is the big bit. Otherwise, it sits nowhere. That information, it's genetic, sits nowhere, and it dies after it leaves the room. Two people have that conversation. Even after you leave the room, they'll have a different recollection of it than you do. 24 hours later, it will be way different. So you want to build, and then before they leave, check what they're leaving with. So ask them for more recall.
So when you're checking, I always find this tough, because you're like, can you tell me what you know, whatever, it just feels kind of wrong. So how do you check?
Yeah. So you could even explain it as a process, so sometimes I am not clear. So it's really important that I check with you what you're leaving with. right? So that you've got the plan. So you can be really specific. You can say, so can you go over the 3 things that you'll be doing next for your cardiovascular disease, whatever, for your medicines, whatever it is. Like, be quite specific and see what people have got. And if they've got 2 out of the 3, like, I've got to get a new prescription, I'll be taking that nightly, I need to stop the other one. If there's anything else, and there was that other one, that you'll need to drink lots more fluid now that you're on this new one, right? So be specific and say, fantastic. You can say, if it's more of a sort of diagnosis and a new condition, you could say, so what's the sort of important stuff that you're going to be talking about with the family? What's happening next? What are the medicines that we've discussed? What's the treatment plan now? What are the options you're going to explore? So be quite specific around what are you leaving the room with. You have to check what they're leaving the room with, because saying, do you have any questions, isn't sufficient, because they may not, but they may be leaving with a completely different picture than the one you were trying to build.
Another case, if you've got a young adult, let's say a 16-year-old woman who is really hesitant to start hormonal contraception, she's heard on social media generally that hormonal contraception has all these different side effects and risks, and that it's just generally bad. She's also not keen on a copper IUD or condoms, so you're kind of stuck with options. What sort of things would you have for that sort of consult?
Medicine distrust is as much an emotional experience as it is it's not necessarily about the science. So even things that help people work out along the way, am I experiencing any of these things? So it can be, do you want to try something and you can keep coming back if you have, you'd come straight back if you experience any of these things, because some of these are things that will go away and other things, it's not a one and done conversation, because it's just safety. People are worried about their safety. You've got to admit, with the amount of media coverage of medical mishaps and investigations, be it system level, be it corporate corruption, people don't necessarily feel that it's all about me, that you're doing the best for me. And so the more you can sort of make it about them and you having a relationship, I think that's really key.
What are some common misconceptions that you have encountered among clinicians on what health literacy is, or whether someone is actually health literate or not?
Sure. The biggest one is that it's something you have or you don't. So you're either health literate or you're not health literate. Everybody has health literacy, otherwise they wouldn't be alive. In the same way that everybody has a level of financial literacy, right, or they wouldn't be able to survive in our economy. So we don't pre-learn after university, or after school and university, we don't pre-learn about everything we might experience just in case we do. The time you learn about something is when you're experiencing it or when you're trying to prevent it. And how you build your skills and knowledge very much depends on the quality of the information available to you at the time and the relationships that you have with the people that have that knowledge. So most of it is about experiential learning, lived experience, and getting a good Q&A going as people are going through something. So it is all about the health response, the health system sector professional response to the needs that people face. So that's why you're asking these questions at the start, to find out what people know. It is not about how good your reading skills are, because very little information in health is actually learned or through reading. It's a bit like saying health is like playing the piano. You can read about it all you like. It doesn't mean that you can manage it, right? You're doing it all the time. You're doing it. So it's much more of a spoken skill almost than it is or an observed skill than it is about reading and writing. So think about it from that perspective. But there's this interesting sort of paradox that we're talking about here, where people can be highly health literate and still be uncertain because they read and read and read and read and read and read, and there's a lot of conflicting information out there. Now, we could say that that's because maybe they don't know how to identify the credibility of the source. That's a whole different level of literacy, right? That's like this academic rigor kind of thing. We can't expect people to be coming with that. So health literacy and agreeing with what the doctor wants or recommends is not the same thing, and nor is you have it or you don't. Everybody has some. You've got to work out where they're starting and build from that. Knowing a lot about asthma if your child has asthma, is understandable. That doesn't mean that you therefore understand a lot about cardiovascular health. Like it's just this whole, you get expertise in what you've experienced, but not generally. And it is fair that we don't generally remember how our bodies work until we're faced with the reality of them not working. Most of the language in health is difficult and unfamiliar, or we use terms that mean other things in other places in health, such as a practice nurse. Practice nurse would be somebody who's still training, trying to get good at it in order to be a nurse. They're still practicing, right?
Oh, true. Yeah.
Had it said from a patient, I don't want the trainee nurse, I want the good nurse, right? So, we adopt these words that we think nothing of and use them in health, and they confuse people. And then, of course, we've just got the actual health lingo that is really tricky. So the more we can talk about things like the pipes that the blood flows through rather than arteries, veins, or vessels and things, let's not make language the barrier.
Some of the qualities of influencers are that they can feel like, they're in their bedroom, they're in a really unintimidating environment, they are using easy words to understand, things that probably people do want a bit more from their doctor. Are there some misconceptions or things that we're not doing to help ourselves in general practice be more relatable and accessible for our patients?
Health professionals come into the room assuming that they are conveying that sense that I care about you, I am only here because you are really important to me, your health is my priority for being. That is not what people read from the room. Okay, so you have to say it and find the way to say it that feels sincere to you, that is sincere to you, but you need to say it out loud because people aren't picking up on that and just assuming that of healthcare professionals, despite it being an absolute reality.
Right, yeah.
Yeah, so say it. Don't assume that people know it just because you're saying, oh, that's, it's nice to see you again. And that's really hard.
So yeah, you're smiling and you're nodding. That's not enough.
That's not enough.
Yeah.
No. When they do those surveys around, does the health professional care about me? The health professional's going, absolutely 100%. I'm so worried about them. And they're going, 50-50.
Yeah, right.
So, yeah, go for the explicit. I am only trying to find out what's going to work for you type stuff.
Could you talk me through the ask, check, build model?
Yep. Okay, so Ask, Build, Check, it's based on an adult learning theory about how we grow our understanding of things. And we each have something called sort of schema about every topic that we've ever committed to memory. And it's how we hold information together and store it in our subconscious. And it's all the bits that we connect. And I like to think of that schema as a tree because it grows and it connects to new ideas. So if you can connect to somebody's schema, the tree grows, right? And it's stored and it's protected and supported by the bigger tree that's providing life source. If you put in random bits of information that just sit there like seeds on the ground, they don't know what to do, right? Nothing's looking after them and they die. So you're asking questions to find out people's schema because you've got to try and connect new stuff to that. And some people have massive schemas, so you have to try and sort of focus. So, about your medicines, what do you know about those? Other people might have very small schema, and you have to work out how much can I add or not, right? So the building part is where you're providing more information, but linking it to what people have said. So a little bit like the gout situation where you say, that bit about the men in your family get this. That's because we now know there's quite a significant kind of genetic component to this, and that's what creates the storage of the uric acid, however you want to do it, right? So you're connecting. So your story is absolutely what's going on here. And then the checking that you've been clear is before you leave the room, it'd be really great just to make sure you have what you need. So could you go through the medicine changes? Could you go through the next step? Could you go through whatever it is that you want to focus on? Once upon a time, we thought the build stuff was quite straightforward. So, asking, and then you all, as GPs, all have different techniques for building. But we actually realised that asking and building that is getting more sophisticated as the misinformation is out there and things. So you really have to check more on the asking. And it doesn't have to be all at once at the start. You can keep asking questions along the way just to clarify, oh, so why? What else have you heard about that? So what else? But because the asking, it identifies how people feel about things, why they believe what they do, not just the facts themselves, but the rationale. That's all part of your schema. And sometimes you're helping people reshape their rationale, not just the fact. It's not just telling people what is wrong or what is different, but why, right? So with the build, you might add in information and connect it, but how you do it, the stuff we've been talking about with empathy, with establishing trust, that you're doing this with people, that they could explore it, that it's not just you providing information, that they've got part of the picture already, reinforcing everything they know that's useful, making them the expert in them. That's all part of Ask, Build, Check. The alternative is just delivering information to people and not being entirely sure what they know already, or assuming that they know nothing or everything. And you get this spiel that you can go through each time. And while that may seem efficient, it is not effective. So you've kind of wasted your time, and that's the downside, right? I got through it tick, but if you did the check at the end, you'd find that a lot of that didn't stay. So try this. If you can build, you can draw pictures, you can talk in metaphors, you can do whatever you like, but the connect. Think about how people are talking about stuff and work out how to connect to what they've got. And they leave with this bigger picture. And they'll keep it. It'll grow, it'll thrive, it'll be stored away.
And so if you're trying to take away that ginkgo extract or the glycoproduct or whatever, the graft you're trying to take away because it's harming them, what are some words or some questions and approaches for that?
So what you're trying to find then is, in their schema, there'll be something that is helpful and accurate, and then people just have extrapolated out this next step that's kind of gone off. And if you can come back to the bit where you're in complete agreement with them and graft on a new idea that connects to the tree that way, connects to the schema that way, then it will flourish, all right? Because you've made, and it might be the opposite point to what they thought it was, but you've connected it to their prior knowledge. So it will grow, and the other stuff will become less loud, and it will just sort of drift away eventually. But you've got to work out where you connect in order to shift. So you're not always connecting to the last thing that people know, or the big picture, and you're just adding bits. Sometimes you're having to go back and sort of help reshape the knowledge a little bit so that it supports a new conclusion.
Cool. Carla, if you had 3 key take-home messages for our listeners today, what would those be?
Use Ask, Build, Check to find out more about what people are bringing into the conversation. And that can help you decide the direction of the conversation without going down a pathway that you assume, is the way to go, only to get to the end for them to say, oh, but I really don't like medicine. Find out at the start what you're working with. So Ask, Build, Check can get you there. Think about how people are presenting in terms of their readiness to change. If they're talking to you in ways that describe uncertainty about a behaviour change, treat it like that. Respect the uncertainty, unpack it with them. Uncertainty is a survival instinct. We all have it, and the only way to get through it is for people to work out, do the pros outweigh the cons? So go through it with people and make sure they're really seeing the full picture. And be yourselves, be empathetic, and let people know how much you care about their well-being. They don't always realise, and I think that's a real shame and a real gain if you can do it.
Cool.
Okay.
If you're a New Zealand GP and would like to claim CPD points for listening to this episode, our podcast is eligible, so please log them. You will find links to any relevant resources that we've discussed in this episode on our website at goodfellowunit.org. And if you'd like to get in touch, we do value your feedback, so email us please at podcast@goodfellowunit.org. Thank you for listening.